maintain a watertight globe and maintain a structural integrity of the globe. So we have to clearly explain the patient, even though any trauma is minimal or it's severe, we have to explain the patient about we are doing the surgery, all the procedure to save the eye and not for the vision initially. So secondary goal should be removing any disrupted lens fragment, vitreous, repositioning the uveal tissue, relieving the vitreous incarceration, removal of foreign body, and restoring the normal anatomic relationship. So corneal thickness tear can be a partial thickness or full thickness. Or sedal should be done in every suspected case, and modified sedal using giving compression should also be done in all cases. Even though a partial thickness corneal tear, it's always better to do a suturing because it always reduces the astigmatism and maintain the topographic relationship. So always better to do suture if it is near the visual axis. So whenever the full thickness corneal laceration, always keep in your mind there is a possibility of foreign body. You have to explain the patient initially only, and you have to do the imaging. And if you are planning to take the patient to the OT, you have to give a deep plane of general anesthesia or a peribulbar block without massage. A speculum should be chosen which is not compressing the globe. Bridal suture should be avoided, and you should not use providone iodine that can cause toxicity to the intraocular structures, and ocular surface should be well irrigated. Whenever AC is shallow, you have to give a side port incision, and through that incision you have to form the anterior chamber with viscoelastic. It's always better not to use cannulas and knife etc. through the main wound entry. So we usually prefer 10-0 nylon. We all know this diamond shape. The length of the wound compression actually is equal to, so length of the wound compression is actually half of the suture length. So if you are doing a long sutures, there will be compression on both sides, it's half length. So you can reduce the number of sutures. If you are doing the small length sutures, compression will be less. You have to do multiple sutures. And if you are taking the bite, take bite at 90 degree, and the depth should be at least 90 to 95% of the cornea, and it should enter through the other half also through the 90 degree apart, and then come out providing a wood apposition without gape. So if it is shallow, there will be internal wound gape, and if it is deep and passing through and through, there is a chance of microbial contamination. So all sutures should be 90 to 95% depth of the stroma, and should be 1 to 1.5 meter in length and equal depth on each side. So whenever a shelve laceration, you should oppose the internal aspect. So it should be off in the internal aspect and not in the external aspect of the wound. Should be keep in mind in all shelved incision. You can see the second picture, that is the ideal suturing in a shelved incision. You should try to oppose the posterior part of the wound. And long wound involving the pupillary area, you have to make sure you are making long sutures in the periphery and come short and superficial sutures in the central visual axis. So you start from the periphery, you take long and deep bite. When you go through the central area, make it short and superficial. It gives the better anastomosis and gives less astigmatism in the post-op period. So the main important thing is the planning of the surgery. You find out the first anatomical point, mostly in the limbus in most of the cases. You anastomose the limbus first, then make the wound into two equal halves, then suture on the either side with equal tension. Always try to do no-touch technique. Do not hold the wound edge, that create the ragged ends. So try to do a non-touch technique, and bury not always. After burying, just make sure that the suture knot is lying just behind the stroma, so that it's easier to removal and there will not be a wound gape when you remove the suture. So in complex wounds, you may have to use bridging sutures or persisting sutures. Which is not opposing, you can use any patch graft or tissue adhesive like cyanoacrylate. So that should be also in your hand when you are planning to do a complex suture. So whenever there's a uveal prolapse, you have to clean the iris or choroid tissue whichever is there. Always try to preserve the iris. Making a side port using viscocannula or using a spatula, you can remove the iris and closely suture the wound. Or whenever there is a vitreous strands, you swipe the vitreous from the anterior chamber. And whenever there is a corneoscleral laceration, as we already discussed, first suture the limbus, then progressively suture the cornea, then suture the sclera. So for sclera, many of us prefer to use absorbable sutures. If it is long wound, you can use even non-absorbable sutures also. So you go through a close as you go technique or zippering technique. The most posterior extension, it is not always have to be sutured. You prefer to leave the most posterior aspect and should be always be careful the wound that is near the muscle insertion. As you know, sclera is thinnest there. Exploring that area should be done carefully. Thank you for your attention.
Thank you, Dr. Irshad, for excellent presentation of the even the very minute techniques of corneal suturing, how to suture, how to place the knot, and how to approximate the wound. Everything has been explained very well.